Good afternoon, everybody. My name is Victoria Lancey, and I'm the Education Coordinator for Michigan Center for Rural Health, and we'll be facilitating this program. I would like to welcome everyone to today's legal grand round on MACRA, the Merit-Based Incentive Payment System, and what you need to know. Brought to you by Michigan Center for Rural Health and Hall, Render, Killian, and Heath and Lyman. Before we begin the program, just a couple reminders. If you are logged into the webinar portion and have computer speakers, you may listen to the audio through them. If you are listening to the audio portion through just your phone, handouts are located on our website for you to follow along. Our website is www.mcrh.msu.edu. Click on the education link on your left, scroll down, click on Legal Grand Rounds, and find today's date. And there you will see the presentation along with attendance form and an evaluation link. There's no continuing education for this program, but the attendance form and a evaluation are helpful for us. Please complete these forms within 2 weeks or by August 31st if you wish to receive a certificate of participation. If you would like to ask a question during the program, please type it into the chat box so you don't forget it, and the presenter will address it during the Q&A portion at the end of the program. Our speaker today indicates no conflict of interest, and the Planning Committee did not have any conflicts. There is no commercial support for this program. I am pleased to introduce our speaker, Brian Bauer, who is a shareholder at the law firm of Hall, Render, Killian, Heath, and Lyman, and has over 20 years of experience in health law. With that, I turn the mic over to Brian Bauer.
Well, thank you, Victoria, and good afternoon, everyone. Certainly a beautiful summer day here in Michigan. Well, a year ago in April 2015, you had new legislation that got rid of the perennial SGR fix that needed to be done. As I'm sure all of you know, the SGR was the short acronym for Sustainable Growth Rate, which tied increases, or in some cases, reductions in physician fee schedule compensation to the gross national product of the country. First few years, it worked great when the GDP was moving along. However, when the economy kind of went the other way, the legislation would actually have required rollbacks in physician compensation, and that's why every 6 to 9 to 12 months we had this stopgap or Band-Aid or short-term fix for that legislation to make sure that physician compensation wasn't actually rolled back or reduced. That went on for a number of years until April of 2015 when we got MACRA, specifically the Medicare Access and CHIP Reauthorization Act. And so that forever got rid of the SGR and the need to fix that, because it replaced it with a new acronym and a new payment methodology or payment adjustment methodology called the Merit-Based Incentive Payment System, or MIPS. Excuse me. The MIPS program, in addition to basically outlining or changing and establishing a new way for physician fee schedule to get updated and increased, or as we'll see, decreased or reduced. In addition to creating that MIPS program, MACRA did away with 3 programs that we've been familiar with and dealing with for a long time. The Meaningful Use Program, PQRS, and the Physician Value-Based Payment Program. So those programs are they're in existence. They're going to continue through December 31, 2018, but then they disappear. They actually get merged into and they're replaced by the MIPS, because the MIPS actually incorporates some of the same concepts, but it really modifies it and creates a new program altogether. So what exactly is this MIPS, this Merit-Based Incentive Payment System? Well, under the MACRA legislation, CMS is or was required, they've actually published a draft rule here a month or so ago, and the final rule is due out in November of this year. But CMS was charged with creating a methodology for assessing provider performance. Then the requirement was to use that methodology to calculate a composite performance score, or a CPS, for each provider, 0 to 100. So every provider that is covered or subject to MIPS is going to have a performance score that's either 0 to 100, somewhere along that continuum. And then the program, the MIPS program, then takes that composite score and uses it to calculate the payment for the provider. So that's referred to as the MIPS adjustment factor. So that composite score is going to dictate what the physician pay fee schedule will be for that physician in the future. Now, if you just looked at the legislation, and we've talked about this, I've talked about this at least one of the Michigan Center for Rural Health Conference presentations, we looked at the fact that the adjustments for the fee schedule under MIPS doesn't actually start till January 1 of 2019. This year, part of last year, second half of last year, this year, next year, the adjustment factor is a 0.5%. And so the actual payment adjustment under MIPS doesn't start until 2019. However, the first performance year starts January 1, 2017. So what we're seeing under MIPS is, starting with January 1 of next year, we're actually seeing the MIPS reporting requirements and performance score calculations. That starts next year, January 1 of 17. The actual impact on payment, however, will not start until January 1, 19. It's a little unclear in my mind when you will start to see the CPS scores, or the composite performance scores, for each of the providers on the Medicare Compare website, but that will come. I think I would expect to see it probably sometime in 2018, after we've had a full year of reporting obligations and trying to work out some of the bugs. Do know for sure that it will impact payment starting 1/1/19, and I'm 99% sure it will be up on Medicare Compare by that time. So who does MIPS apply to, or who's subject to MIPS? I mean, traditionally, the SGR fix, you'd think of that as impacting the physician fee schedule and any adjustments, annual adjustments to the physician fee schedule. Well, MACRA and CMS is MIPS applies to every Medicare enrolled physician and each and every Medicare enrolled mid-level providers. So CRNAs, nurse practitioners, PAs, and basically every other Medicare enrolled provider, clinician. In fact, that is the term that MIPS use to apply to all of the providers, whether they're a physician, nurse practitioner, PA, CRNA. They're referring to them as a clinician. So basically every Medicare enrolled clinician is going to be subject to MIPS. And when I say subject to MIPS, what I mean is they're going to have to do the MIPS reporting, submit the data reporting that MIPS requires, and their future payments starting in 19 will be adjusted based on the payment adjustment factor, which again is based on the composite score. So each clinician that's Medicare enrolled is going to have to do the reporting, and they will have a composite performance score. Now, there are some exceptions. I think the exceptions are going to be relatively few in number as far as who's going to get out from underneath MIPS. The first one is newly enrolled in Medicare. Obviously, if the first time you are the physician or mid-level provider is coming out of their residency or training program in 2019, well, there is no data upon which to base that score. So that first year, when a provider is newly enrolled in Medicare, they're excluded from MIPS. They're not covered by MIPS. That obligation starts year 2. There is also an exception for certain low-volume clinicians, certain low-volume Medicare clinicians. And the threshold is $10,000 or less in Medicare billed charges and 100 or fewer Medicare beneficiaries receiving care from that clinician in that year. So if a clinician is either a concierge provider or maybe a physician that for whatever reason it just has a small payer mix of Medicare, or maybe a clinician that is in a part-time status, part-time retirement, part-time status for other reasons, it is possible that those clinicians, if they have less than $10,000 in Medicare charges and fewer than 100 Medicare beneficiaries seen, they will also be excluded from the MIPS program. Then we have this category of those accepted or not required to, or not covered by the MIPS payment adjustment. And that applies to those clinicians that are participating in advanced alternative payment models. There are alternative payment models, which include things like patient-centered medical homes, the Medicare Shared Savings Program, and there are advanced alternative payment models. The Medicare Shared Savings Program Track 1, which I know some of you participate in, does not qualify as an advanced alternative payment model or advanced APM. Track 1 does not qualify. Track 2 and 3 would qualify. Patient-centered medical homes by itself is an alternative payment model, but it is not an advanced alternative payment model. So that would not get the clinician out from underneath MIPS. However, participating in CPC Plus, if you're participating in the Comprehensive Primary Care Initiative Plus, which there are 14 regions in the country now that are eligible to participate. One of them happens to be Michigan statewide. So obviously, for those of you that are interested and that otherwise meet the qualifications to participate in CPC Plus, that participation would qualify you as being an advanced alternative payment model. And then if you are a professional, a provider, a clinician participating in that alternative payment model, advanced alternative payment model, then you get a new acronym. You are a qualifying professional or a QP. It's amazing. Maybe I should have given this in a little bit more of introduction, but this MIPS is a significant shift in how physician compensation is going to be paid. There still is obviously the fee schedule, and for the particular codes that are provided, the particular services that are provided, those don't change. MIPS, of course, changes the amount for which the employer if the provider, the clinician is employed, or the individual clinician if they're in solo practice or have their own practice. It will adjust how they are paid. So that adjustment up or down, how much the actual amount of payment on the fee schedule. But it is clear from the proposed rule that one of the goals of the MIPS program is to incentivize, some people might say push, that's a little editorial, I guess, but their language is to incentivize clinicians to move into and become participants in advanced APMs, alternative payment models. So there is definitely a real incentive to do that, and that is part of the push. But there is just a ton of new acronyms. It's almost like a new language. And one of the things that I'll suggest here in a minute, and kind of what you should be doing now, is, you need to educate yourself. And my goal here is not to get too deep into the weeds, but is to hit the high points, the starting point for you guys. So alternative payment models, advanced alternative payment models, professionals that are participating in those would be exempt from MIPS, at least the payment adjustment, because some of becoming a qualified professional under the advanced alternative payment model depends on attribution. I believe everybody, even if you are in an advanced alternative payment model, you probably will still need to be doing the MIPS reporting. In some cases, you can use the, if you're in the Medicare Shared Savings Program, you can use the Medicare Shared Savings Program quality measures and reporting, but you're still going to need to do the reporting. So I think, generally speaking, for probably 85 to 90% of you, I would not be looking or thinking you're going to get out from underneath the MIPS reporting or the MIPS adjustment by being a participant in an advanced alternative payment model. Some of you will, but I think for the most part, I think you need to be thinking and planning that you will be subject to MIPS. Keep in mind that the payment adjustment under MIPS does not start until 2019. So even if in 2017 and 2018, which are the performance reporting requirements or periods, you may still be subject to MIPS, but you may be migrating, you may be building towards it. I think you need to plan on starting with MIPS and then build out from there. All right, so with MIPS, we know that there is that CMS is required to come up with a methodology for creating a composite performance score for each clinician. And basically what that requires is there are 4 performance categories: quality, resource use, clinical practice, improvement activities, and advanced care information. Advanced care information probably in its current state would be meaningful use, but it's EHR implementation. Each individual clinician is going to receive a composite score based on their performance in each of these 4 categories. Now, the quality measures, and there are a number of quality measures that the individual clinician can report on, they're going to be reported every year. Think of it almost along the lines, for those of you who have a need to and regularly look at, each year CMS publishes about this time of year or in a little later in the year, an update for the IPPS reimbursement, an update for the OPPS reimbursement amounts, and an update of the fee schedule, the physician fee schedule. Those get published every year this time and apply, obviously, for the following year. That's what's going to happen each year under the MIPS program. We are going to get a series of tables that have specific quality measures, and the regulations and the statute actually require that these quality measures be published prior to or by November 1 of each year. So we're going to get this list of quality measures each year. So we have these 4 categories, and we're going to get the quality measures published each year, so we know what we have to report on and what the scores are and how we're going to be able to score. And then CMS will establish, in addition to the quality measures each year, a performance threshold. And the performance threshold is important because the providers who have a composite score at or above the performance threshold will receive a 0. I mean, if it's right at the performance threshold. Let's just make it simple for our discussion today. Let's say the performance threshold is 50. If the composite score for the performance threshold is 50, then if your individual clinician has a composite score of 50, there will not be an adjustment. The payment, the fee schedule for that clinician in the previous year will be the same in that following year. So let's just apply specific dates in years. So if your clinician has a performance, a CPS, a composite performance score of 50, and the threshold is 50, they will receive in 2019 the same payments for the same services that they received in 2018. If, however, their composite score is a 60 and the performance threshold is 50, they will actually receive a positive payment adjustment. We don't know for sure what that positive payment adjustment is. We know that it will be, if the threshold is 50 and your clinician is 60, they will get a positive adjustment. But if you have another clinician and their CPS is 95, they will get a higher adjustment. So it's not like a winner-take-all in the sense that if you're just above 50, of 50.5, you get the full positive adjustment. No, if you're just above, you'll get some positive adjustment, but those who have higher scores will get higher adjustments. So it's a graded or increasing amount. The flip side is if your clinician has a performance score below the performance threshold. Again, if our performance threshold is 50 and they have a score of 45, the amount they will receive for the same services in 2019 will be less than they received for those services in 2018. And the negative adjustment is also graduated. And so that if the performance threshold is 50 and your clinician has a performance score of 45, they will have a reduction in their fee schedule payments. If you have another clinician whose performance score is 25, the reduction will be more. In other words, that clinician who received or has a composite score of 25 will have a greater negative adjustment, so the amount they will receive will even be less than your clinician that had a score of 45. So it is potentially a big impact. Now, you'll see here that in 2019, the adjustment is 4%, going up to 5, 7, and then 9% in future years. Excuse me. So, if we're talking about this adjustment in year 2019, and again, assuming for discussion that the performance threshold is 50, and you have an individual clinician who has a score of 55, they won't get the full 4% positive adjustment. They'll get some positive adjustment, but not the full 4%. Whereas if you have a different clinician they're at 95, their composite score is 95, they potentially will get the full 4%. Same thing is true on the negative side. If the performance threshold is 50 and you have somebody at 46, they will have a negative adjustment. It won't be the full 4%. Whereas if you have somebody that has a composite score of 10, they probably will see the full negative performance. Now, the thing that I find important, worrisome, troubling, I don't know what exactly the right word is, significant, maybe that's the best word here, is the two bullet points, the two bottom bullet points here. This program, this MIPS program, is budget neutral. So in order to ensure there is positive adjustments, there has to be negative adjustments. And so the performance threshold in a given year is the mean or median. CMS has the flexibility for all MIPS providers, again, that's everybody, for a prior period selected by the secretary. So in the performance threshold for 2019 might be the mean or median for 2018, or it might be the mean or median for 2017, or some sort of combination thereof. What CMS and the secretary are going to do is make sure that roughly 50% of the providers are below the performance threshold and 50% above. So that means roughly half the clinicians will get a positive increase and half will get a negative increase, because it's those receiving a negative increase or getting a reduction in their fee schedule that are going to be paying for the increase in those that receive a positive adjustment. So obviously, this is especially for those of you that employ your physicians, and I think probably most of the folks on the webinar are listening in today are hospitals, RHCs, FQHCs that employ your physicians. The amount that you're going to receive from Medicare is going to be based on your individual employed physicians or mid-levels, clinicians, performance scores. So obviously, you have this dynamic where you have employment agreements and you have salaries and benefits that you've committed to these providers, but the amount that you receive for their services on the fee schedule is going to be tied to their performance scores, which brings up an interesting concept that I think you all should be thinking about and looking at, and that is your physician or your clinician employment agreements. Right now, I'm guessing that none of them are tied to your composite performance scores, all too new, unless you were really on the ball and paying attention last April and did something between now and then. My guess is that mostly none of you have this. Some of you probably are tied to RVUs and other performance metrics. I think it's going to be important that you start thinking about this and thinking about how you want to roll this in. Because if the physicians don't hit certain performance scores and they have a negative adjustment, obviously, and if you still have to pay the full salary and benefits, it's going to be a losing proposition. All right, so the MIPS scores, let's talk a little bit about how those performance scores are actually calculated and how they're assigned. So CMS is going to assign these performance scores at the individual clinician level. So think NPI. Each clinician's NPI their individual NPI number is going to have a composite score tied to it. Now, if the clinician bills under more than one tax identification number or TIN, just thinking you may have some part-time mid-level providers that provide services for you and another employer. Another example probably would be employed emergency room physicians and emergency room mid-levels if they staff your ER part of the time, and then they also staff another hospital's ER part of the time. CMS is actually going to assign a composite score based on the tax identification or employer number and the NPI combination. So think of it this way. Each clinician, based on their performance, which we'll see especially with regards to quality, is going to be tied to individual quality metrics, quality reporting. Each clinician, each NPI will have a composite score tied to the reporting through that tax ID number. So if we're thinking about a clinician, whether they're a physician or a mid-level provider that's employed in one of your physician practices, they're only going to have one composite score because that clinician bills just through one tax identification number, whether you have a separate one for that practice or whether they're all provider-based, and so they're billing through the hospital's tax ID number. That one provider or clinician is only providing services at that one location, and so they're only going to have that one composite score. If, however, they're employed at two locations, they'll have two composite scores. The import there, or the consequence of that, is that your score for that clinician at your location will adjust or drive what your payment, the adjustment to the fee schedule is for your tax ID number for that clinician. So in other words, if you're very good at getting up to speed on MIPS and what MIPS is going to require, and you help that clinician get a high performance score, and that performance score is going to go and stay with your tax ID number, with your entity. And so it's possible that the same clinician could work in two different locations, have a composite score of 95 with your organization and a composite score of 45 at another location, because it's going to be, a lot of it's going to be tied to reporting and some organizational activities that the clinician will have less direct control over or impact on. So the thing that's going to be important is making sure how that clinician performs at your locality for your organization under your tax ID number. You don't have to worry about how they do down the road. If they only score 45 down there and you've got them at 95, it's going to be your 95 that's going to impact your reimbursement. So you don't need to worry about how they do down the road. You need to worry about how they do in your organization. If a clinician moves during a year, their composite score follows them. This is going to add a new wrinkle to all of you as you do recruitment for clinicians. In addition to other performance metrics, you're probably going to want to know what their composite score was, and if it was low, why it was low. So if you're hiring a nurse practitioner or a physician assistant in 2018, you're probably going to want to know what their composite score was for 2017. And if it's low, why it was low. Was it something that the individual clinician had the ability to impact and change, and thus will potentially drag your scores down? Or is it something some aspect of the 4 categories that the organization has more control on, like EHR, for an example. And so the fact that they had a lower score there may not impact their score when they come to work for you, other than the fact that if a clinician moves during an adjustment year, you're stuck with their adjustment. So if they had a composite score below the threshold, again, let's say for the sake of discussion that threshold's 50, and they have a composite score of 35 at their old employer, and they come to work for you, that composite score and its corresponding negative adjustment, they come to work for you in 19 or 20 or 21, that negative score and negative adjustment is going to impact the amount of reimbursement you get for that clinician for the rest of that year, that reimbursement year, calendar year. And so, again, you can see all the ripples that come off of that. If that person comes over to you in January 15 of 2019, you've got their negative adjustment to deal with on your reimbursement for that full 2019. On the other hand, you have most of 2019 to get their performance score up to, above the performance threshold. Whereas if they come to work for you in November of 2019, you only have a negative adjustment for 6 weeks or so, but you only have 6 weeks to get their performance up. So just more things that you're going to have to be thinking about with regards to recruiting and employing clinicians. Now, the calculation of the clinician's composite score for performance year 2017 is weighted in this fashion. So first year, 50% is going to be based on the quality measure reporting, 10% on the resource use, which in some ways is very helpful because it is going to be hard to have a direct impact on that resource use score, at least initially. For those of you that are participating in patient-centered medical homes or the Medicare Shared Savings Program, and you're already developing care coordination processes and programs, you're going to be better off, as we'll see in a minute, but the resource use starts off at 10%. The Advancing Care Information, or ACI, again, think of this as the old, it's streamlined and I think improved meaningful use scores is 25%, and then the clinical practice improvement activities get scored at 15%. And that's in year 2017, which of course is not an adjustment year, just a performance year. 2018, the ACI and the CPIA stay at the 25 and 15%. In fact, they stay at that level throughout, but the quality and resource use allocation or weighting shifts from 50-10 to 45-15, and then in the 2019 performance year, which of course is also the first payment adjustment year, it shifts to 30 and 30, which is where it remains throughout the MIPS program. So resource use becomes more important, and I raise and point this issue out because, as we'll see in a minute, it's harder to have a direct hands-on impact, a direct cause and effect impact on that resource use score. The resource use is based on the actual cost to the Medicare program, and so you need to actually build into your operation either through the clinical and practice improvement activities or others, which you get some of this under the EHR, the ACI, I shouldn't use its correct new acronym, Advancing Care Initiatives, but you need to get these programs like care coordination implemented in order to be able to impact the resource use throughout the system in aspects or parts of the healthcare system that you do not directly touch. Okay, so quality. Starts off at 50, goes to 45, keeping in mind your performance score in 18 is going to drive your adjustment in the future. So quality is going to be important. Clinician, to generate your score under the quality category, the clinician or the group must report on at least 6 quality measures. Now, it's interesting because the group can report, or the individual can report, the individual clinician can report, or both can report. If both reports actually, and by that I mean if the group reports based on the group's performance, that'll generate 1 score, and if either the individual clinician or the group on behalf of the individual report individual scores, it's possible that an individual clinician would have 2 scores, one based on the group reporting, one based on the individual's reporting, in which case CMS will use the best of the 2 scores, which is a nice plus, is a nice thing. But what I want to say is the clinician or the group can report under the quality category. They must report on at least 6 quality measures. There is a huge selection of quality measures. They can select from the master measure list, or there is actually a specialty specific measures list. Now, not every specialty is included, and so if your specialty, your clinician's individual specialty is not on the specialty clinics list, then you're limited to selecting the 6 quality measures from the master list. But it's in one respect, I'm probably dating myself, but it's like when you went from airwave TV, when you got probably, depending on your market, 6 to 8 TV stations, to cable, when you got 700 stations. There is a huge variety to select from. You only have to choose 6. You have to report on 6. You've got this wide variety, and again, if you're in a particular specialty and you feel that that specialty measure is better suited for your clinician, you can use that. So you have to have at least 6. Got these 2 measures lists to choose from, or these 2 types of measure lists to choose from. One of the 6 must be a cross-cutting measure, and it's in actually a different table that's listed. There's only 10 of them. CMS believes that, hence the name cross-cutting, that it goes across a variety of high priority issues and healthcare changes that CMS wants to implement. And so at least one of the 6 must be from that 10 listed on Table C, and one of them must be an outcome measure. There's a lot of process measures. At least one of the 6 must be an outcome measure. So you got to choose 6. One of the 6 has to be cross-cut. One has to be an outcome measure. The other 4 can be a cross-cut or not, can be outcome or not. That's going to be up to you and obviously your clinicians. This is why it's going to take some time, and why you guys need to be starting now, figuring out which one of these measures, what you want to have your 6 measures be. So you have the highest possible score, so you have the highest possible performance, composite performance score, so you have the best chance for receiving a positive adjustment. Yes, so may report on, each clinician may report on more than 6 scores. CMS will use the best 6 scores. So the minimum is 6. You got to have the one in the cross-cutting measure, the one outcome measure. But if you want to report on 10 instead of 6, you can do that. You can report on 15. You can report on as many as you want. CMS is going to use the 6 with the highest scores. So actually, you know, if you're able to do it, if your organization and practice is able to do it, I recommend that you do more than the minimum 6, because they're going to take the highest scores, and so you kind of improve your chances. Plus, you get bonus points, which you can earn bonus points that has the ability to improve your score in your quality score up to 10%. So for each additional outcome or patient experience measure, you get 2 bonus points. For reporting any other high priority measure, you get a bonus point. And for every measure reporting using certified EHR from end to end, you get a bonus point. So lots to be thinking about here. Resource use, and this is what I was talking about, and I think it's important to pay attention to the fact that even though it starts off at only 10% of your overall composite score, or your clinician's overall composite score, it goes up to 30%. And here's how it's calculated. Clinicians are not required to report. CMS is going to use claim data to calculate the scores for this category. And to generalize a little bit, but CMS is calculating the total per capita cost, the Medicare spending per beneficiary, to calculate each provider's, each clinician's RU score. Now, Medicare is proposed, and I've mentioned this in a couple presentations as well, Medicare has proposed a modified attribution methodology, the idea being, okay, let's really see which type of physician, which specialty, which clinician in the entire continuum of care is most responsible for resource use. If it's the primary care physician, given a particular spend, then it's going to be the primary care physician. If it's a specialty physician, then more of that resource utilization will be allocated to the specialty physician. There's not, in my mind or my sense, enough clarity in this area yet, but it's coming. That's an alternative. Plus, CMS is proposing some new episode-based measures, kind of like the comprehensive joint replacement program, those sorts of episodes of care for allocating resource use between the providers, the clinicians along the continuum of care. The Advancing Care Information, and again, this is the new acronym for meaningful use. It's a combination of base scores and performance scores. To get the entire 50 base score points, it's pretty simple, at least initially, under the performance metrics we have under the proposed rule. And that is, if you basically answer each of the questions that hit these 6 objectives, you're going to get the full 50 points. So this one is, I don't want to say it's easy. I think it's probably going to be a little tougher than I make it sound, but it's basically if you answer the questions, you're going to get the points. I do have to point out that if you fail to answer or respond yes to the protection of patient health information, which is one of the 6 objectives they have under the ACI, you don't get any points. So if you're not protecting your PHI, no surprise, you're not going to get any points in this area. Clinical practice improvement activities, or CPIA or CIPIA, I don't know how that acronym is going to be pronounced here in the future, but CMS has proposed over 90 activities. All you have to do is make sure and certify that you're engaging in activities that total at least 60 points, and you get full value for this category. We get a couple extra bonuses here for those of you that are in rural areas or HIPSAs, which is going to be a lot of you. You get 30 points for each activity. So you only actually have to do 2 activities, certify engagement in 2 out of the 90+ activities to get your full points under this category. So you need to figure out which two you want to pick, get them done, get some easy points. Clinicians, those of you that are participating in an ACO in the MSSP, you're automatically going to get 30 points. And so you actually probably, if you're in a rural area, only need to do one more and you'll get your full 60. I'm not really encouraging minimum performance here. I'd probably do more than that to make sure if the final rule comes out and it's a little different, you make sure that you're getting your points. And then groups that actually have full patient-centered medical home designation, you automatically get your full 60 points because what you're doing as a part of the PCMH, you're already doing the CPI activities they're looking for. Important note, if you have a clinician that fails to report, or you on behalf of your clinician fails to report in a timely and compliant manner in a given category, you get 0 points for that category. Nothing will drive you below the performance threshold faster than not reporting in a timely and compliant manner. So start paying attention now, figuring out how you're going to get that reporting done, what's required, who's going to do it, how it's going to get done. Start working on this now. I think the first key is educating yourself, your practice managers, and your clinicians. You're going to have to engage your clinicians on this, and you probably sooner the better, to make sure and work with them to make sure that you're going to be able to pick the quality measures that are necessary to get your maximum score, to start developing care coordination and other processes that will impact the total Medicare spend for your attributed patients, to make sure that your resource use score is as high as you can. I want to put in a little plug for the Michigan Center for Rural Health. There is actually, the MACRA has in its legislation appropriation for technical assistance and training, and that specifically is earmarked for practices of 15 or fewer, with priorities given to practices in rural areas, HPSAs, and medically underserved areas. And I know the Michigan Center for Rural Health is partnering with a larger provider to provide that educational services and technical assistance. So I think once the final contract awards come out, you'll probably be hearing more from the center on that. All right. There is another slide. For whatever reason, I'm not able to advance. If you can, for whatever reason I can't, Victoria, if you can. If not, it's obviously it's up on the website. But as far as start now, what you need to be doing is you need to be putting together, in addition to what I have on this screen, but also putting together work groups to evaluate and select the quality measures your clinicians or groups are going to report, to evaluate and select those clinical practice improvement activities that you're going to use, and to evaluate which ones will work for you, what you can do to make sure you maximize that. Ensure your clinicians or group can respond to the ACI, the EHR measures for the 6 objectives. Make sure that you get all of those done. And like I said, in this case, it's going to be almost as simple, at least this first year, as responding to the questions to get the full 50 base points. There is requirement as to EHR utilization, percentage of that. Obviously, you get more points, as we said or saw, on end-to-end EHR use. So you need to have these work groups put together to be looking at this. Work groups on the resource utilization. How can we start moving? And for those of you that are already involved in an ACO, you're already doing some of that now as a part of the shared savings program, that care coordination, continuing to build on that, because if you are track 1 MSSP, which I think probably applies to everybody, if not most everybody, if not everybody, you're still going to be under the MIPS. So you still want to be, that care coordination effort and reduction in spend is going to benefit you both under the MSSP and MIPS. So you want to be building on that. And then another topic for a work group is actually kind of a longer term approach. And that's having a work group explore how your organization can mature into an organization that can participate in advanced APM. Because you get out from underneath the MIPS adjustment, you get a standard adjustment plus a bonus on that, and there is a real, you still end up having to do the quality reporting and most, if not all, of the MIPS reporting if you're under an advanced APM. But the adjustment, you don't have to worry about, where your composite scores are. You're going to get the advanced APM adjustment, and keep in mind that because that composite score threshold is tied to budget neutrality, in theory, year one, the threshold might be 50. But if you have a bunch of people improve so that, basically everybody's at 80% or above, then the threshold might be 90 because, half are between 80 and 90 and half are 90 and above, and it's got to be that half win, half lose. So anyways, I apologize. There's only a couple minutes left for questions. I'm certainly welcome to take any questions, and I can, Victoria, I can hang on longer beyond the time frame. Happy to do so if there's questions.
Okay. I have a question in the chat box. It says, how does this work with RHCs? Will we no longer have the AIR? Can you handle that, Brian?
I'm sorry. I don't know the answer to that right off the top of my head, but what I will do, Victoria, if you forward that question to me, I will send a response back to you and you can return it on.
Yep. I can definitely do that.
Happy to do that.
Yep. Are there any other questions or comments for Brian? Are there, then there's another one. It says, are there any exemptions from MIPS? Yes, exemptions from the MIPS include, and then they have, it goes on. Providers in their first year billing Medicare.
Yep.
And then it says, is this correct? Additionally, it is anticipated that providers practicing in rural health clinics or federally qualified health FQHCs are exempt from MIPS. And then it says, it gives a website, aafp.org.
I think that is correct, yes.
Okay. I can send you that as well.
Yes, and then I'll give a more detailed answer.
Okay. If you go down to the chat box, Brian, you can see all the comments.
Oh, all right. Very good.
I will send all of these to you in an email. Are there any other questions or comments for Brian? I can unmute all of the lines too, if you would like.
Whatever.
Okay, so you have all the lines unmuted. Are there any questions or comments?
Yeah, this is Diane from South Haven. I'm just looking at the paperwork again to find where to find these slides to so I can share these with my coworkers. And the website Where do I go? It's www.mcrh.msu.edu.
Yep,
Where
and
do I
then click education on your left, and then
Okay.
from there, legal grand rounds. And then I can always send them out to everybody as well,
Okay.
if that's. Are there any other questions or comments?
That's it.
Okay. If we don't have any other questions or comments, or if you have a question or comment for Brian later, you can feel free to indicate it on the evaluation, and I can pass those along to Brian, or if you can email me directly, and I can pass those along to Brian as well. Thank you for joining us, and everybody, and have a great day.
Thank you.
Thank you, everyone.